I'm Tennent Slack, the clinical chair of the Think About It campaign, which is a program dedicated to reducing deaths associated with prescription painkiller drugs as well as illegal narcotics, principally in the form of heroin. We have some very important supporters of this program. The program is primarily sponsored by the Medical Association of Georgia Foundation, which works very closely with the Medical Association of Georgia. The Georgia Society of Addiction Medicine is also a key sponsor and is vitally interested in this arena. The lecture today will consist of two parts. Part one is going to relate to the overview of this subject. We'll look at some statistics. We'll look at the law in the state of Georgia, which supports the ability of a citizen to use this reversal drug. And of course, we'll talk about what pain-killing drugs are and what the reversal agent is, we call naloxone. This prescription overdose death problem has been an issue in the United States since around the year 2000, and we've seen a steady rise in overdose deaths. It looked like around the year 2012 and 13 we were going to see a leveling off or even partial reversal of deaths after many years of escalations. Unfortunately, in 2014, the data revealed that we once again saw a sharp increase in the number of deaths associated with prescription drugs. Concomitantly, over the past several years, we have also seen a sharp rise in the number of deaths associated with the illegal narcotic known as heroin. It's important to note there's a very strong link between painkiller sales and deaths, so that the annual volume of prescriptions is closely tied to the number of overdose deaths. So you see, as the prescription volume amount goes up, the death rate goes up, and when it drops off, the death rate drops off. So in the state of Georgia, we are very fortunate to have a law that was passed in April 2014, HB 965, which does two basic things. It provides immunity for those who are assisting an overdose victim, and secondly, it allows a health practitioner or a non-health practitioner, meaning regular citizens, to be able to administer this reversal agent without any fear of being prosecuted. So what are opioid drugs? These are these substances, the key constituents of these substances have been with us for thousands of years, initially being found in the opium plant. Wasn't till about the 1800s, though, mid-1800s, that we were actually able to isolate the drugs morphine and codeine from the plant. And since that time, we have been able to come up with several other, quite a number of other painkiller narcotics, which all act like morphine and codeine, which come directly from the opium plant. So the entire class of drugs is called the opioid group. So these drugs work at very specific areas in the brain. Probably there are two big issues with this group of drugs in terms of side effects. Number one, as you all know, these drugs can be very habit-forming and in some individuals profoundly addicting. Secondly, though, even if you don't have an addiction problem, this group of drugs is especially deadly in terms of its ability to slow down the breathing rate in human beings. And when you combine that slow breathing rate with its ability to suppress the cough reflex, you have a real prescription for overdose death. And that is really unique to this group of drugs. There's really no other drug class that acts this profoundly on breathing. And this, of course, is especially dangerous when you combine the painkiller drugs with alcohol or anti-anxiety pills like Xanax, Valium, muscle relaxants, antidepressants, any other type of drug or substance that slows down the central nervous system will magnify these side effects of the narcotics. So some examples of prescription opioids. As I just mentioned, the drugs that come directly from the plant are morphine and codeine. And since that time, we've developed a number of other pain-killing drugs, some of which are derived from morphine and codeine. Others have been synthesized from scratch. We all have heard of hydrocodone and oxycodone. These go by the trade names of Lortab and Percocet, among others. Fentanyl, methadone, Suboxone, Demerol are all other drugs that you may have heard of. And all of these drugs have a similar potential to be deadly. There are a couple of these drugs that come in the form of a patch, and so if you arrive on a scene, you do need to be careful to look for patches. In other words, it's not always going to be a pill. There are people that can abuse patches. There are two basic types of patches, the fentanyl patch and the Butrans patch. Of those two, by far the more likely to be abused will be the fentanyl patch. So why do you think I have an arrow here pointing to the mouth? Well, the reason is because some people will put these patches in their mouth and try to ingest them in order to obtain the drug. So if you arrive on a overdose scene or a suspected overdose scene, you want to look in the mouth to see if there are any of these patches, and to see if there's anything obviously obstructing the patient's ability to breathe, which we'll talk about in just a second. These patches, providers, whoever the rescue person is, whether it's professional personnel or civilians, you need to be careful if you're taking off these patches, because the fentanyl material can get on your skin and be absorbed by you. So you want to exercise caution when you remove these patches. You might, in fact, you probably want to wear gloves or use a rag. It'll introduce something between your skin and the patch if you're taking them off. So as I mentioned earlier, the principal illegal narcotic is heroin. This is a drug that is very, very similar chemically to morphine, and it is a drug that is typically injected. And so people tend to think that heroin is somehow more deadly than other narcotics. The reason it is because it is injected. If you take any opioid and inject it directly into the circulation, it is going to be very, very dangerous in terms of its ability to stop breathing. So what is the reversal agent that we're talking about? The generic name of this drug is Naloxone. It goes by the trade name Narcan, and it's been around for several decades and used extensively in medical practice, both inside the hospital and more recently by emergency providers on the outside of the hospital. FDA approved in 1971. And the principal way that it works is, you heard me say that the opioid group acts on receptors in the brain. And so what naloxone does is go and sit on those receptors, and it does not turn on the receptors. It just sits on the receptor and tends to knock off the opioid, which is the green circle, tends to knock the opioid off the receptor, and the naloxone just sits on the receptor and does not activate it. And the result of that is profoundly effective reversal of the respiratory or the breathing slowdown that the narcotic causes. So what is the onset? Well, as I've just referenced, that's going to depend on the route of administration. If you introduce the drug intravenously, of course, that's the quickest. Intramuscular, that is in your muscle, is also going to be very quick because there's a lot of blood vessels inside your muscles which take the drug up and send it to the central nervous system. A slower route is the intranasal route. That means in the nose, and that is the route that has been approved for anyone to use. And I would emphasize right off the bat that the safety profile of this way of administering naloxone, that is through the nose, has proven to be very safe. There are very few untoward events using the drug in this way in an overdose scenario. So if you use the drug in the nose, onset can be, there are going to be several factors which determine the onset. And not the least of which is the patient's circulation. So if if the heart is not pumping blood around, then regardless of however you give the drug, it is not going to get into the brain. So that is a very important point to understand. When you give the drug through the nose, it can onset quite rapidly, anywhere from 2 to 3 minutes, or it could take several minutes to onset, even as high as 8 to 12 minutes. When you give it in the muscle, much quicker, probably more reliably delivered to the central nervous system, anywhere from 2 to 5 minutes. The duration of effect of the reversal effects, roughly half an hour to an hour. There have been a number of concerns about how we are going to store naloxone when it's going to be used in the field. According to the drug specification, needs to be stored around 68 to 77 degrees. You want to avoid direct exposure to sunlight, and that's common sense. The shelf life of naloxone tends to be pretty long, up to 5 years. And there has been concern about, well, what if the drug has exceeded the shelf life? And our answer to that is giving the drug is better than not giving the drug. And if that's all you have available and you're trying to save somebody's life, you should go on and administer whatever naloxone product you have available to you. Now we're going to move on to part 2. We're going to show some nuts and bolts of how to actually administer the product. So the first step is to make sure that you're comfortable in recognizing an overdose scenario. Fortunately, that is relatively easy to do. Everybody pretty much understands that an overdose victim is going to be sleepy and difficult to wake up. The more important assessment is going to be if they're breathing or not. And it's relatively easy to get an idea of how much they're breathing. You can just simply put your finger under their nose or a couple of fingers over their mouth and see if air is actually moving. You also might look at the chest to see if it's rising and falling. And if it is not, then they're not breathing, and you have a likely painkiller overdose scenario. You also can look at the pupils. Again, if you watch TV, then you'll know that a lot of narcotic overdose victims tend to have very small pupils. So once you have identified that you have an index of suspicion for narcotic overdose, then you would move ahead with the administration of naloxone. So as I mentioned, there are two major ways that a non-medical person can give this substance. One is through the nose, and the other is in the muscle. We're not really going to go into the in the muscle product. It is a commercially available product. They have a website, and you can go and visit the website and purchase the product directly off the website if that's the type of product you want to use. We are going to be really focusing on the intranasal products, and in the video that we have in this particular lecture, we are focused on the product that is on the far left. And more recently, this product you see here on the intranasal product on the right has been released, and I'll mention that briefly after we go through the details of using the first kit. So the basic outline of the step-by-step treatment, very easy. Step 1, make your assessment, develop your index of suspicion. Step 2, this is a very important, call 911 immediately. You want to get help on the scene. Number 3, get your naloxone ready to give and give it. And once you've done that, then you want to turn the victim on their side and provide a little bit of chin lift so that you can facilitate their ability to breathe and move air in and out of their lungs. So again, the naloxone is doing all the work here. The naloxone is what is going to restore the patient's ability to breathe. Now, an important caveat here is if the victim is not breathing at all and or they do not have a pulse, then you do need to consider breathing for them, and you need to consider giving chest compressions. As I said earlier, it doesn't matter how you administer naloxone, whether you give it in the vein or the nose or the muscle, it is not going to get to the brain unless there is circulation. And we'll talk about chest compressions again in just a minute. So here's a video we put together of a real-world example with audio, and let's let you look at that.
Are you okay? Are you okay? She's not breathing. Call 911.
Okay, now that you've seen the video, we'll go through once again, step by step, and review. Step 1, assess level of consciousness. One very effective way to assess somebody's level of consciousness is to do what's called a sternal rub, and you saw the young lady do this in the video. Basically, you just take your knuckles and rub it on the patient's chest plate. Very, very stimulating, and will give you an idea of how easy it is to wake the patient up. Secondly, you want to check again how much the patient is breathing. Check for airflow. Put your fingers over the mouth and nose. And you want to give a rough assessment of how often they're breathing. So you're looking you want to see at least one breath every 6 seconds. That's generally considered the cutoff, so that's going to be 10 breaths a minute, and if you see 10 breaths a minute or less, then it is appropriate to give naloxone. Now, we're talking about an estimate here. This is, you're not tied to a definite number. If you suspect the breathing rate is 10 times a minute or less, perfectly acceptable to give the naloxone, and in fact, it is safer to go ahead and give it if you think the breathing rate is slow. Call 911, as I said earlier. You want to prepare your delivery device. In this video, again, we use the device that I showed you that was on the left. If you're using that device, that first one that we talked about, the one on the left from the earlier slide, we recommend using half the dose in one nostril, half the dose in the other nostril, although if you want to give the entire dose in one nostril, that's fine as well. The point is really to give it. Once you have done that, turn the victim on their side and provide the chin lift that we talked about. Now, an important consideration, which we'll cover in a little bit more in the next slide, is if the patient, if you detect that they have no pulse, or you're concerned that they have no pulse, In order to deliver chest compressions, you are going to need to have them flat and on a hard surface. So you see in this picture, this young lady is on a sofa, and we've already turned her on her side. But if there are no pulse, then if you're going to give chest compressions, you would need to put this young lady on the floor on a flat surface, face up, and then administer your chest compressions. So let me also just quickly show you how to use this other device. This is a very, very simple device. It's all in one. There's really no assembly required. The drug is already contained inside a little cavity here. All you do is put this in the patient's nostril, push up on this, and you deliver the entire dose in one nostril. Very, very easy. This is the Adapt product. Okay, so after you've given the naloxone, there's several things to consider. Number one, if the patient has thrown up, you want to do what's called a mouth sweep or a finger sweep. You open the patient's mouth and simply sweep your fingers through the mouth cavity to make sure there's nothing obvious blocking the patient's ability to breathe. We've already talked about rescue breathing and chest compressions. It's very important to continue to monitor and to support the patient while you wait for help to arrive. And that would include monitoring their breathing and their pulse to the best of your ability. So things to expect. The patient may throw up as they wake up after you give them the naloxone. Don't expect that. They may be very agitated and combative, and you need to expect that as well. There's a lot of concern about this particular component, that the rescuer could potentially be injured by someone waking up from an opioid overdose. It is true that an acute reversal of an overdose, the patient can be very agitated, confused, combative, swinging, all of those things. But looking at the larger picture, the goal is to save the person's life. So expect them to be agitated and combative and be prepared for that. And as part of that, they could wake up in opioid withdrawal, which means that if they are habitual users of narcotics, they can be especially combative and agitated when you suddenly reverse all of that. So just be aware of all of these things. So closing thoughts here. And this is very, very important. If you suspect there's an overdose, just give the naloxone. If you suspect that the vial may be out of date or you're concerned about that, just give the naloxone. Again, this is a dire rescue circumstance, and your number one goal is to try and save the patient's life. You want to monitor the patient after you give the naloxone, so you want to watch for any kind of relapse in breathing. Understand that the wake-up can be very rocky. You may be dealing with a very agitated patient. In terms of the product that we demonstrated in the video, this is the Think About It product. We recommend that you keep it in a pouch on your person. And of course, if you have to give mouth-to-mouth resuscitation, you're going to be better off if you have a barrier device available. This is a reference slide which is available to you if you want to look more carefully at that. Thank you very much.